talks as well, so we'll see. Load it up, and then we can probably have the next, I'm thinking the next 2 weeks would be recorded content, and then 1 week final, and then the final exam. Or 1 week in person, the final week in person, I should say. So that's my plan, but I'll let you know for sure how that all shakes out. Next week for sure will be online regardless, so no in-face class next week. Okay, so emergency medicine. This used to be my bread and butter. It's where I worked for the majority of my clinical pharmacy career. I kind of have stepped out of that for now, but I feel like I still have a good handle on most of what happens there anyway from a pharmacy perspective. So I want to talk about the stuff you're going to see in the emergency department. A lot of this we've talked about before. There's not going to be a lot of new drugs we're going to talk about today. Some of it might have been just very surface level, so we might go into a little more depth, but kind of want to talk about all the major things, common things at least you'd see practicing in an emergency department, and to some extent in urgent care as well. So let's talk about what paramedics do before a patient arrives and what kind of drugs they have access to. They can pretty much give anything you might need in an emergency medical situation. So anything for a CV emergency, so your ACLS meds, pain medications, including narcotics. They're kind of limited in what they might have. So for example, in the hospital, we have access to any number of narcotics. They probably just have fentanyl. Or like, for example, we'll have all the different benzodiazepines available for a seizure. They probably just have midazolam. So again, they don't have a lot of space to carry their things, and we don't want to load them up with a bunch of stuff they don't need. So it's really the basics, but essentially they have a major drug in every category to treat any pretty much medical emergency, at least to stabilize somebody to get them to an emergency room or department. Okay. Access. So you need to be able to give your drugs first and foremost. That's one of the things that ACLS pushes a lot. You guys haven't had your ACLS. That's coming soon, right? Friday. Okay. So they're going to ask you a lot of questions about this, and you guys know this. Everyone kind of knows this. But of course, you need some sort of way to get drugs into the body before you can get drugs. So I've got some funny videos about IO access there. I'm sure you guys have talked about IO access at some point, right? It's okay. No, I don't know. I don't see it done as much. Usually people come into the field with an IO intact, and then they'll swap it out for a peripheral or even a central if they need to. But usually they just swap it out for a peripheral right away when they get in. It's pretty common. Occasionally we'll use the intact IO, but it doesn't happen too often unless that's absolutely our last choice. And I don't know if it's just the nurses in the ED don't like the IO or they prefer the peripheral. I'm not sure. Peripheral is preferred if you can get a patent one, but sometimes you need the IO. Okay, so let's start with a couple topics that are fast-paced things that happen in the emergency department and some kind of unique things to the ER and some meds that we haven't really talked about in detail a lot. So rapid sequence intubation is called RSI. And so if somebody's airway is not being, if somebody's not protecting their airway, I should say, that's going to be the first thing that we're going to look at doing is intubating the patient. So whenever you have a critical emergency, whether it's a drug overdose or cardiac arrest or something, likely possibility the patient's going to at least need to be considered for intubation. So how do we do this? Well, we do it really quickly. Rapid is rapid. So this whole process takes maybe a couple of minutes to get the tube down somebody's throat into the lungs. And we give medications to support this. So first step is a fast onset short-acting sedative. This is called induction. So we're inducing sedation in these patients. And usually using kind of high doses, but we're using really short-acting things. So if they're going to come off fairly quickly, and that's going to come into play in a little bit later here. But sometimes you might not need them. So for example, if somebody overdosed on a bunch of opioids or benzodiazepines or something like that, and they're already significantly sedated, it's probably not going to do a whole lot of good for you to give them extra sedatives. Or if somebody's in a cardiac arrest and they're unconscious, you don't need to sedate them further. You might want to consider, some people might consider some pain medication, so a little bit of a narcotic in a situation like that, because it might help with some of the unperceivable pain, but it's still, you don't need to induce every person. So it's kind of a situational thing. Certainly if somebody's yelling or screaming or whatever, yes, intubation is going to need a sedative. The drug of choice for most cases is called etomidate. Or Amidate's the brand name. It's a really short-acting, less than 10-minute. It's a non-barbiturate hypnotic. It's kind of like a GABA potentiator, so it's sort of like a benzodiazepine, but not really. It's actually structurally very similar to clonidine, so it has some alpha activity in the central nervous system, so it sort of slows down the whole central nervous system, which causes sedative effects. It doesn't really have an effect on blood pressure. So I said it's related to clonidine, so you're thinking maybe it decreases blood pressure. It actually doesn't. It might drop blood pressure a little bit, but it's mostly neutral. That's really important when you're thinking about what to give somebody as a sedative, because a lot of these people are going to have unstable hemodynamics, and being able to figure out which one is going to be the best here often is going to be determined by what their blood pressure is. So the majority of patients aren't going to have a significant hypotensive effect to etomidate, which makes it pretty universally approved for most indications. Doesn't really have any contraindications to speak of. Ketamine's used occasionally too as an alternative. We've talked about ketamine a little bit there. The nice thing about ketamine, in some cases, it can actually increase blood pressure. So if you have a hypotensive patient, ketamine's a preferred sedative in those people. Propofol is slower than both of these other ones, so it's not preferred just because of that. Ketamine and etomidate are quite a bit faster, and etomidate is faster than ketamine, so still etomidate's our top choice regardless. It's just situationally you might want to use ketamine. I don't recall ever really using propofol for RSI, but you could potentially if you were in a pinch and didn't have anything else. Again, it's got a slower onset. It takes a couple minutes for it to distribute and start working, and it does cause some hypotension, a bit more profound than etomidate. So if your patient's blood pressure is bottoming out already, that's not going to be a preferred choice. Combined narcotic benzodiazepine administration is an option and certainly would work fairly quickly. It depends on what your goal is here. So like, I'm trying to think of an example. Like at our hospital, if we have a patient coming in post-cardiac arrest with return of circulation with a pulse and we're going to cool them, we always use fentanyl and Versed as our preferred both analgesic agent and sedative agents. And so we'd bolus with those at that point. That patient should already have some kind of an airway already, so it's probably a little bit of a moot point, but for the most part, you could use them initially. They're always almost used together because by themselves, they're sedating, but combined, you get a synergistic sedative effect that's pretty profound, and so you almost always see them combined together. So again, compared to alternatives, they aren't quite as fast-acting as etomidate, and you also have two medications you have to give. These medications, controlled substances, it's going to require your nursing staff to take a little bit extra time pulling them out. There's countbacks and stuff involved with that. Etomidate, for whatever reason, and also propofol aren't controlled substances, so you can pretty much pull those out and give them willy-nilly, and no one's going to follow up on how much you gave. So that makes them a little bit easier as far as an access point of view goes. So anyway, the moral of the story is etomidate is preferred unless you have a really specific set of circumstances that's going to drive you to a different one. All right, so that's the first step. You want to get your induction agent on board. Pretty much immediately after you induce sedation in the person, you're going to paralyze them. So again, that depends on how fast your paralytic is acting. If your etomidate's working, normally it's going to sedate them very quickly. If you gave them propofol, you're going to have to wait a little bit. Paralysis should happen after the patient's fully sedated. You never want to paralyze somebody who's even remotely conscious because they'll panic. Imagine if you all of a sudden couldn't feel yourself breathe, couldn't feel yourself move. And sometimes you can actually see that, like if we give somebody etomidate in a paralytic and then 5 to 10 minutes later, see their blood pressure spike suddenly because you didn't get enough sedative on board to continue that effect. So that's one of the things I'm not talking about this second, but you have to continue that too, so that you don't, your paralytic doesn't outlast your sedative. So another reason why we like really short-acting things is because we want the paralytic to come off quickly. So again, your window of time for intubating somebody, 5-10 minutes is usually enough if you have an experienced person doing this. Sometimes people are difficult to intubate. You might need to redose. That happens occasionally. But for the majority of patients, you can do it with just 2 drugs. And succinylcholine is generally preferred. It's got a really fast onset, very short-acting. It's about 10-minute duration. So that combined with etomidate, fast onset, short-acting, both of them work quite well together. They depolarize the motor end plate. It's similar to our natural acetylcholine. If you remember back to last fall, we talked about this a little bit. But basically, it stays on that motor end plate longer, and so you can't get inaction potential to repolarize. Therefore, you get sustained muscle paralysis for a few minutes. Eventually, it just kind of gets broken down by the same pathways the body breaks down acetylcholine. Contraindications, it does cause potassium to leak out of cells. So hyperkalemic patients, you wouldn't want to use succinylcholine in. That's probably the biggest barrier to it. So I think about patients who have missed dialysis, which is a really common presentation for an acute emergency or cardiac arrest. I also think about people with muscle trauma. Abbott's not a trauma center, so I don't see this, but if you're in like a car accident or had a large crushing injury, that's a lot of cell damage, possibly leaking various electrolytes into the circulation, specifically intracellular potassium. So you're going to see potassium usually spiked in those people. And if you give succinylcholine, that can worsen the picture and worsen the whole arrhythmia or whatever you might be seeing, why you might be paralyzing that person. So that's really the biggest issue with Sux is it's short acting, which is, again, good, but if you're having a difficult intubation, it might not give you enough time to get it done, and then also the hyperkalemic part of it being a contraindication. Rocuronium is the second choice. It's got a slightly slower onset, and I always tell providers to give it a little bit of time. People tend to be really impatient with rock, but I feel like it takes like a solid minute for it to kick in, and that can that'd be a really long time when you've got all your people ready to give, put the glide scope down and get the person intubated, and they're all kind of staring at me in the corner with my little syringe, and I'm like, we gave the drug, just wait for it to kick in. Come on, give it some time. It's not instant, not like Sux. So if you're really used to Sux all the time, rock is definitely a different beast. But the plus side is it lasts about 20-30 minutes, so you get about double the duration. So if you want that extended paralysis for more difficult intubation, a lot of times these two choices can come down to individual preference on the provider's part. So you might find that you're better with one or the other. Some providers might always use Sux, some might always use rock, unless they have a really good reason not to. But for the most part, I think Sux is the more common choice, and rock being a second option for possibly more difficult intubation patients. Vecuronium is rarely ever used. I'd probably avoid it in most cases, but it is an option. It's slightly longer acting than rocuronium, so I just thought I'd mention it there. And then some places might start somebody on a long-term paralytic drip. Again, I'm kind of going back to coolit patients or therapeutic hypothermic patients for this reason. So if you're going to therapeutically cool somebody, you want sustained paralysis for usually a day at least, if not maybe a little bit more. And so atracurium or cisatracurium are drugs used to do that. So they'll give somebody a bolus of that and start a continuous infusion. You don't give continuous infusions of succinylcholine, rock, or Vec. It's just not done for whatever reason. You use the curium drug. So again, subtle differences. They all pretty much do the same thing, with the exception of Sux having a different mechanism, and then the curoniums and curiums all being direct acetylcholine blockers versus binding to the same site. So that's really the biggest difference there. Again, provider-specific preference and situational use, but you're really going to see these two drugs used the majority of the time. This is a RSI kit, and I just want to show you an example of something we stock at our hospital. So for example, and I think this is pretty common practice throughout the country, you'd open the paralytics actually require refrigeration for some dumb reason, but you have to, so you'd open the fridge and you can pull this kit out, and it's got 2 vials of rocuronium, 2 vials of etomidate, and a large vial of succinylcholine in it. And the idea is the majority of patients, it's all weight-based dosing too. You can kind of see how we dose the medications here. And so if you have, the idea is this kit alone gives you enough for about a 100-kilo patient or so. If you have a larger patient, you'd of course need more medication. All right. Ketamine is not in the kit because it's a controlled substance. We do stock these phenylephrine sticks. So phenylephrine, peripheral vasoconstrictor, increases blood pressure. So if you happen to bottom out somebody's blood pressure during this process and you want to get it up a little bit, you can give bumps of these too. So we supply those as well in the kit. Rarely ever used, but it's there in case they need it. All right, conscious sedation is kind of like mini RSI minus any paralysis. So basically you're just sedating the person for a small procedure. And like examples, common things you'd see, cardioversions, hip and shoulder reductions, other type of painful invasive procedures, possibly like laceration repairs in children. I see that done occasionally, small doses of propofol and things like that. And in this case, you could use all the same agents technically, like ketamine. Etomidate will work for conscious sedation. You're going to usually dose it much lower, but much more commonly propofol is going to be used, especially in adult populations. From what I understand, and I'm not a peds provider, so I don't have a ton of experience with this, but that ketamine actually is preferred in peds for short-term sedation because kids tend to move around a little bit excessively on propofol, whereas they might not move quite as much on ketamine. Again, both fast-acting, both kind of interchangeable from the effects you get with them, so either one's fine. But propofol is by far the one that we would use at our hospital most commonly for our adult population. Propofol doesn't provide any analgesia, so if you needed some fentanyl or Dilaudid or something like that, especially for a reduction, you might want to consider a little bit of opioid on board too, just to get that pain relief. As your propofol is going to last a few minutes, give them a dose of Dilaudid or fentanyl, and that's going to last maybe an hour or so at least to give them some pain relief. It depends on how aggressively or how much pain you think the patient is. And cardioversions usually don't need any pain control, but certainly a little bit of morphine or something isn't unheard of after a cardioversion. Propofol is weight-based dosing, so just like all these other drugs, we need an accurate weight on the person. Usually you do half a mg per kilo, may need up to 1 mg per kilo. Propofol is really easy to dose, super commonly given. It's infamous for being the Michael Jackson drug, right? It's a non-controlled substance at this point. It's kind of always the threat that somebody's going to control propofol, but I feel like if they haven't at this point, they really aren't, because that whole Michael Jackson thing kind of blew over, and I don't think any major cases of propofol diversion have hit the news lately. So hopefully it won't be controlled, because between the ED and the procedural areas and surgical centers, they use the stuff like water. So controlling it would be a little bit of a logistical nightmare. When people get propofol, they tend to yawn and have a funny metallic taste in their mouth. That's sort of how you know it's onsetting, but that doesn't happen for everyone. Some people also say it burns when it goes in, and people will almost it's funny. Some people have no reaction at all, and people will scream like you're stabbing them with a knife. And then propofol also is in a white emulsion. It's made with eggs and soybean oil, egg whites and soybean oil, I should say, as some of the emulsifying ingredients. So people with food allergies may react to it, probably not, but still, if they have a strong documented egg or soy allergy, probably best to avoid propofol. All right, I have an example of somebody using propofol on a patient here, just for fun. I'm gonna watch a cardioversion. Never seen one.
How you feeling? How you feel? You good? Yeah.
So I think they already gave this guy propofol.
Yeah, I gave him. How much? I gave him 60. I didn't do anything. I gave him another 4. You wanna?
That's good communication right there. Yeah, sometimes oxygen flowing while they do electricity is kind of a no-no, very low risk, but yeah. So a couple things. First of all, propofol, when you're on propofol, you'll still see people move and react to pain. So obviously that guy jumped. That's really common. So I think that was one of the things as a student I didn't really understand when I first saw cardioversion, that you aren't totally out of it. You can actually kind of arouse people too, depending on what kind of stimuli you provide. Ideally, they're going to be pretty out of it before you start it. Like usually they'll do a little sternal rub on the person before they do the cardioversion, or start messing with the shoulder or joint, whatever it is. Make sure that they aren't responding to that, and then they'll go ahead with the procedure, whatever it may be. Propofol is tricky to dose. It is straight weight-based, but oftentimes, and providers have different experiences with this, but two mistakes I see often with propofol are baby doses and trying to eke your way up, which doesn't work very well because propofol distributes strangely. And by the time you catch up, your original doses are almost gone from the system. So I'd really follow the basic guidelines. Do a solid bolus of a half a mg per kilo, give it all at once in a push, and then you can re-bolus on top of that if you need to. And that seems to be, from my experience, I've done hundreds of conscious sedations, or not, I don't do them, but I dose the meds for them. I've been in the rooms for lots of them, and that seems to be what I've seen the best strategy with. Where people go straight with 1 mg per kilo and slam somebody, they tend to get overly sedated, a little bit hypotensive, need some bagging after the procedure. That's pretty common too. So again, stick to the recommendations and you'll do just fine. Fancy that, right? You actually follow the instructions and it works out okay. All right. I just have some providers, sometimes they're like, I really don't like to give a lot of propofol because I had that one patient that bottomed out in their blood pressure, and it's not going to happen to the majority of people. So don't feel bad about giving that half mg per kilo bolus up front. All right, do you guys have any questions about conscious sedation or RSI before we move on? Some other topics? All right, we'll kind of do a review of systems type approach to these topics and move quickly through them. Again, a lot of this stuff we've talked about already, but just to review it from an emergency specific perspective. Stroke. So stroke can either be ischemic or hemorrhagic, and depending on that is the pathway we're going to go down. I'll talk about ischemic a little bit in the acute phase. Hemorrhagic I'll talk about more during our critical care topic, and that's acute, yes, there's some management there, but a lot of times we're looking at ongoing processes for that are more important to talk about in detail. So if you do ICU or do an ICU rotation or work in the ICU at one point, you'll do a lot of, especially if you work in a neuro center, you do a lot of post-hemorrhagic stroke care management. Anyway, so activating a stroke code, that's really an important step, especially for a provider once a stroke is identified, to make sure that you're alerting the correct people. Time is brain is a real thing. Studies have shown that the faster people get TPA or the faster they get whatever intervention is needed, the better they do long term. I put some images up here because I don't know anything about images, but I think the circled parts are where there's blood. or ischemia. I don't know. You pick. Again, they don't pay me enough to read CTs. So, all right. So anyway, the second step, usually they're going to go right to a CT scanner. They're going to get a head CT to see if it's ischemic or hemorrhagic. We have a stroke neurologist on call that either reads the image remotely or is on site, usually on site, who makes that call. As soon as they say ischemic, our pharmacy department usually mixes a bag of TPA immediately. So we have it ready to go. It doesn't come in solution, so it takes a few minutes to make it. And so as soon as we get it ready, we pretty much have a process down where I call, they mix, I stand outside the IV room, like waving at them really annoyingly until they give me the bag, and then I run it back to the ED. You can't tube TPA in like a pneumatic system because it's a big protein and it could denature it, so you have to manually transfer it. That's why. So again, I'm getting into too many details about TPA that you guys don't care about, but the point is we have a really down pat process for getting this done fast, and minutes are really valuable in this time period. So our stroke neurologists are really aggressive at Abbott. We're a well-recognized stroke center for a reason. We have great metrics, but we work really hard at it too. So we have these processes down, and there's a number of team members involved in that. And the whole point of me talking about this is just because when you activate that stroke code, that gets everyone prepared so that imaging's ready, pharmacy's ready, your nurses are ready. Everyone's kind of prepared for what to do with a stroke. Stroke care isn't that complicated. Giving TPA is really easy. Making TPA is super easy. It's expensive, but it's really easy to make it. It's just a matter of doing it sequentially and quickly once the green light's given. And so that's where sometimes the communication fails, where somebody tells somebody to tell pharmacy this and no one told pharmacy, and then pharmacy gets yelled at by somebody for not doing it when no one told pharmacy to begin with. Never happened to me once. All right. Okay. No, seriously. Most of the time it goes pretty smoothly. And again, we're looking at having a really low response time. Once we get the go-ahead, it's a couple minutes before we can get TPA infused, unless there's access issues. That's different for blood pressure issues, and we'll talk about that in a second. For ICH, again, I'm not going to talk about this a ton, but basically you want to stop any anticoagulants or antiplatelets. You want to stop any sources of bleeding if you can. Manage elevated intracranial pressure. So usually in the emergency department, we're going to look at a focused approach to this. It's going to last, hopefully not a long time before the person can get transferred somewhere else. Mannitol and hypertonic saline, when given to a patient in a large bolus, can shift the concentration gradient and can pull fluid out of the brain so you reduce intracranial pressure. And that's the whole goal immediately. Now, after that, there's some more things you can do, like manage the blood pressure, manage the anticoagulation, or reversing the anticoagulation, if you need to. But that all kind of comes sequentially after that. So really, from an emergency perspective, I just want you to know that we lower intracranial pressure, and we use that with mannitol or hypertonic saline. Our neurology group prefers hypertonic much more so than mannitol. One odd thing about mannitol is the product itself forms crystals in the bag or the vial, so you can actually see it crystallizing, and you have to warm it up sometimes. So we have this little warmer. It's kind of like an egg incubator in our pharmacy that keeps the product actually at a temperature that's supposed to be dissolved. But sometimes people forget to put stuff in there, or all your products still crystallize even though it's in the warmer. Hypertonic saline doesn't have that issue. It never crystallizes. It comes in a little 30 ml vial. You give it, push, it works really fast. So it's just an easier product overall. You would never give that product to somebody who wasn't absolutely about to die from an ICH, though. That's really dangerous. It can shift concentration gradients in the body. It can really mess with electrolytes. And somebody who didn't have excess fluid and blood in the brain would probably die from that. So it's a very high risk thing. We talked about 3% saline, right, when correcting sodium deficiencies. This is not a typo. It is 23% hypertonic saline. It's a lot of sodium to give somebody in one shot. But ICH outcomes are not great. And if you have a blood bleed to the brain, it's kind of like you throw the kitchen sink at the person trying to stem it, stop it, do whatever you can to save the brain function. And even then, it's difficult to do it, unfortunately. Reversing anticoagulation is kind of the next step you'd take. So start your reduction in intracranial pressure at the same time. Most commonly, probably going to see warfarin, but with the new anticoagulants, you're going to see those coming in a lot too. PCC, or prothrombin complex concentrate, is still the gold standard for any anticoagulation reversal with the exception of dabigatran or Pradaxa. So all the factor Xa inhibitors, rivaroxaban, edoxaban, apixaban, all three of those common ones now are going to be reversed that same way. And I'll talk about the alternate agent here in a second. But first of all, let's review PCC. PCC is just clotting factors injected into somebody. PCC works really well and really quickly. Like we do a follow-up INR check 20 to 30 minutes after somebody's given PCC, and I see INRs go from 10 to 1 consistently. It works really well. So reversing warfarin, highly effective. When it came out, since there wasn't a reversal agent for the factor Xas, people just started using it because people are bleeding into their brain. What else are you going to do? You might as well give it to them and try it. And it actually showed in several studies that it's fairly effective for reversing factor Xa inhibitors. Dosing is pretty easy. I don't care you know the dose, but it's based on weight, it's based on INR, and then you pick a choice there. It's really expensive, but again, you're talking about like a life-saving treatment for somebody. And then it's a one-time thing. You usually don't redose PCC. Sometimes it's kind of rare. And then you want to start vitamin K too. That's a really important step that sometimes people forget, is the vitamin K needs to be started on board so that once the PCC starts to wear out of the system, you might still have warfarin floating around and suppressing clotting factor production. So giving a large dose of vitamin K will help the body make more clotting factors on demand over the next day while things start to stabilize and that anticoagulation effect can diminish a little bit. So what about the new drug Adexanet alpha, which is the factor Xa specific reversal? So first of all, it's about twice as expensive for a full dose as PCC. Second of all, its outcomes actually aren't that good. So we did a little study at our hospital looking at everyone who was reversed with PCC from a factor Xa inhibitor bleed in like the last year. We looked at 50 patients or so, I can't remember how many it was. Anyway, I'm not going to go into all the details, but their outcomes were actually better than the study design outcomes for what got Adexanet alpha approved. So from that perspective, we decided it's not worth excess cost. We'll keep using PCC, save some money, and hopefully have better outcomes overall. We're still watching it, but we've decided not to use it at this point. And then Pradaxa is different. PCC doesn't really work well for dabigatran or brand name Pradaxa. So you actually do have to either use factor 7 or the Praxpine product, which is a specific product designed to reverse Pradaxa. So that is different. That one is proven better than PCC. But again, for the factor Xas, we still use PCC for those. Okay, for your ischemic patients, you have, again, we talked about TPA, so does the patient qualify? We talked about this during stroke already, so I'm not going to rehash a lot of the contraindications. The big things I always think about in the ER stage, you always want to keep the big picture in mind, right? What are your huge, outstanding contraindications you need to remember at the time when you're at the bedside making these important decisions. Time frame. So there's the time frame that's specifically designed for TPA. 3-hour window preferred, 4.5-hour okay. There's some studies coming out to say that maybe there's no time frame, that you can do it at any time and get some benefits. So that might change soon. Bleeding. Does the patient have recent surgery, recent bleeding? Are they currently bleeding? Those are all contraindications. Anticoagulation. Are they therapeutically anticoagulated? That's a contraindication. And then blood pressure. Blood pressure cutoff, knowing that 185 over 95, getting that right? I don't know. Again, it's been a while. But systolic is probably the one that's often the big one. So labetalol is the one we use a lot. Short-acting or boluses give you a relatively long-acting effect. You can do a drip too, like a nicardipine drip or something, and we'll talk about those in a second more in detail. Migraine, we talked about migraine already, but this is a really common ER presentation, as you guys might know. A lot of people who come in with migraine have a history of these. They have a treatment plan already from their neurologist. So sometimes it's kind of like plug and play. They give you a list, and all right, we're going to give you a big dose of steroids. We're going to give you valproic acid. We're going to give you ketorolac. We're going to basically give you the kitchen sink, except for narcotics. It's kind of what a lot of these treatment plans look like. If it's a new patient, you're not familiar with it, see if they have a neurologic history or they've had experience in the past with different medications. Basically, again, we're trying to avoid narcotics. So just to review our options here, we have a couple things we can do. So are they taking triptans at home or have they maxed out on their triptans? So remember, all the triptans have a max daily recommended dose. Usually the max dose that's prescribed orally can be done twice. So for example, sumatriptan's highest dose for a single use is 100 milligrams, and you can do 200 milligrams 2 hours apart in a 24-hour period. And usually they're all kind of like that, but they all have different doses. So it's best to look them up because there's 5 or 6 of them that are pretty commonly used. If not, if they haven't maxed out, you can give another dose and get them to the max of their triptan, get them intranasal, or you could consider giving dihydroergotamine if they haven't done any triptans at all. It's a little bit more potent. People might respond to it better. If triptans aren't on the table or you've already given them and nothing's happening, ketorolac is another choice, and prochlorperazine as an antiemetic is a nice option too. Those are probably the two I would go with. As far as antiemetics, you could use metoclopramide, you could use ondansetron, but Compazine tends to have better data with it slightly for reducing migraines or being better at treating an active migraine. But again, the data is kind of weak. It's just a personal thing that I've seen over the years. Ketorolac, it's your only IV or IM NSAID. It's your best choice at getting the most potent NSAID in the body as fast as possible. So again, if you're going to kind of go big or go home, it might be the best choice. There is some data out there that says that people, if you placebo control it and inject somebody with saline and give them a tablet, compared to people given ibuprofen orally, it's not any different. People respond the same way. So maybe NSAIDs just don't work all that great for migraines, but certainly it's not going to hurt the person to give them one dose in most cases. Their kidneys and GI tract probably would be just fine. And then you've got the other options that get more complicated. It's the IV valproic acid, the high-dose steroids, usually methylprednisolone, and then finally narcotics are kind of your last choice. Again, super, super common ER urgent care presentation, migraine. Status, we talked about benzos already, but just to review our status options. We've got 3 drugs basically that you're going to be looking at for status patients. 3 IV available benzos, lorazepam, diazepam, and midazolam. Lorazepam is going to be used in 90% of the situations. You might have people wanting to use some of the other ones here and there. EMS will give Versed or midazolam because that's what they have on their rig. They usually don't have the other 2. Diazepam has odd stability, and it's been on and off shortage for a while. It's been hard to get a consistent supply of it, and IV that is. And lorazepam requires refrigeration, so that makes it less likely to be available in an ambulance, whereas midazolam doesn't. So it's a much more stable product. There's also really great data. I think I talked about this during neuro, but for midazolam intranasally. So you can give it with a mister and hook up the IV product into a syringe, put a little atomizer on the end of it, squirt it into somebody's nose, and it has very fast onset. Great for kids too who are thrashing around or people with hard to get IV access. It's a really common way of delivering benzos for seizures. A very effective one. Benzos are short-term temporary seizure stoppers. They work great, but they wear off, and you don't want to keep somebody on a benzo long-term, so you need something immediately to get them longer-acting benzo therapy. So it depends on the patient, right? If they have, or it's longer-acting anti-seizure therapy, I should say. So if they have Keppra history, if they use Keppra and missed a week of doses or whatever it is, obviously Keppra would be your go-to. If they don't really have much of a history, Keppra is probably still your go-to, but you could really go with a number of different choices. I don't have IV divalproic acid on here, or Depakote, because it's not really used for acute epilepticus. You might use it for if you could stop the seizure and then you wanted to redose the person because they're on Depakote at home, that might be okay. I just didn't put it on here because it's not a seizure stopping medication per se directly. But these drugs actually, let's say you aren't getting the effect you want with benzos, they will help stop the seizure in addition. So you can give a big load of Keppra to stop a seizure, kind of almost as effective as a benzo. But again, somebody's seizing in the field and they get picked up by EMS, they're going to get benzos because EMS doesn't have any of this stuff on board. They're just going to have the benzodiazepines with them. They might have propofol, but I don't think so. I know they won't have any of these 3. But you have a few choices is what I'm saying. So you can go down the list until you get something that works. Some people don't respond well to benzo, especially some certain childhood seizure disorders don't respond well, and you have to work your way down until IV propofol would be really rare, but it does work. To sedate somebody with propofol does tend to stop their seizure activity. All right, meningitis, just really quick. Talked about this with peds and last fall. True bacterial is rare, but needs to be taken seriously because mortality rate's high. Basically, get your lumbar puncture with your CSF sample, start your antibiotics. For most adult patients, vanco and ceftriaxone is what you're going to do. We talked about kids already, not going to rehash that. If you're over 50, they add ampicillin onto it. It's a pretty straightforward regimen, and that's about it. Sometimes they do dexamethasone boluses, and that's for if you have a potential Streptococcus pneumoniae pathogen involved as well. It's a little bit controversial. The clinical evidence for it's a little sketchy, but it may prevent neurological complications long term. The idea is it decreases the inflammation overall from the meningitis, but the problem is that can actually decrease your CNS penetration of vancomycin. So that's why it's controversial. Vancomycin's a big, chunky molecule, and if your meninges are inflamed, it actually allows the vanco to travel through them easier because they're leaky. Whereas if you decrease the inflammation with Decadron and they get tighter and tighten up those gaps, then vanco can't get through quite as nicely. It will get through eventually, but it gets better if it's so the question is what's better, decrease the inflammation to protect the central nervous system in general, or do you keep the inflammation going so you can get the drug in and kill the bacteria? I don't know. I think, again, the trials are inconsistent with that. All right, cardiovascular. Any questions on neuro stuff before we move on? Okay, hypertensive crisis / urgency / emergency, whatever you want to call it. High blood pressure with symptoms is probably a better way to talk about it. Lots of people come into ERs or urgent cares or whatever and have really high blood pressure with no symptoms whatsoever. There's not a lot you have to do with those people. I think I hear lots of older physicians getting really, well, I've got a couple of physicians that I work with who are really ornery about certain things, and I just have gotten this drilled into my head that usually you don't need, high blood pressure by itself can be treated doesn't need to be treated aggressively, I should say that. So, of course, if you have progressive and organ damage signs and symptoms, that's different. But for the average person, even if they're 200, 220, you don't need to put them into the hospital overnight. Usually what we're going to do for an urgent situation, again, an asymptomatic person who just has really high blood pressure, is look at reducing blood pressure over a day or two with oral agents and follow up like in a couple days and make sure it was sustained effect. My general strategy for this is if they're on an antihypertensive already, just increase the dose. If you don't have any room to do that, check out the classes they're on and see if there's something obvious they aren't on. So remember our 4 major antihypertensive classes, our beta blockers, our ACE inhibitors, our diuretics, and our calcium channel blockers. So I'd go with one of those 4 if they aren't already on one of those. If you want something that works fast to see if you can bring it down in the ER or in your urgent care, I've got some options for you here and I'll show you on the next table that actually work pretty fast with oral onset. And your goal is to reduce your blood pressure to 160 over 110 over the next hour to days. Make sure the patient follows up and gets appropriate management of their condition if they need to have medication adjustment or be started on new medications. It wouldn't be inappropriate to prescribe them something to take continuously. So maybe you give them a prescription for lisinopril and send them out the door. I've definitely seen our ER docs do that, and that's certainly appropriate in this particular scope because you don't know necessarily when they're going to be able to get into clinic, and you want to make sure that their blood pressure doesn't spike again. So giving them 10, 15, or even a month's supply of something isn't all that, is definitely appropriate, I would say. Okay, so if you want some oral fast-acting options, most of our standard drugs like lisinopril and amlodipine take a little bit of time to work. They'll usually start working within a day or two of taking, and you usually see full effects from a week. But if you want something faster, clonidine is kind of the one I always keep in my back pocket. It's got a 15 to 30-minute onset, at peak about 2 to 4 hours. So you could keep somebody in your ED for a couple hours and probably see the effects of clonidine on their blood pressure in real time and see if it's going to respond to medications. Now, why do you need to do that versus discharging them? It's, again, if they're asymptomatic, it's a little bit debatable, but you do have that option to reduce it pretty quickly with some of the oral things. Nicardipine oral, usually from what I've read, has an onset closer to the 30-minute to 60-minute mark versus the 2-hour mark. It's a quite fast calcium channel blocker. And labetalol. The labetalol is another one, but a little bit longer onset. I don't see captopril really ever used. It's just not common. No one's going to stay on captopril long term. Its duration is really short acting too, so you don't get as sustained effects from it. So tend to avoid that one if you're looking for a fast option. And again, we're talking about something that's going to bring them down while they're sitting in your ER, not necessarily something you're going to send them home on. So certainly you could send them home on clonidine or labetalol, but it would be an odd choice. You'd probably maybe try that and then give them something to sustain them like lisinopril or something more common to send them home on. All right, emergency, or again, hypertension with symptoms. There's really no cutoff for what this could be. If somebody has end organ damage and their blood pressure is elevated, it could be 150, it could be 220. It doesn't really matter as long as you're addressing the underlying cause and treating the symptoms that they have. So hypertensive emergency doesn't necessarily have a specific definition anymore. Acute end organ damage, common things that you might see. Of course, you could see the really drastic things like acute intracranial hemorrhages, myocardial infarctions, dissections, aortic dissections, things like that. Pulmonary edema, acute renal failure, so increased serum creatinine, vision changes. Also, encephalopathy could present as acute mental status changes. Treatments, you're going to use an IV antihypertensive agent in these patients, and I've got a bunch on the next table here. Your goals are to reduce a little bit more aggressively than last time. So first hour, 10 to 20% reduction, additional 15% reduction in MAP, controlled blood pressure reduction over 24 hours to target your MAP based on whatever your goals or whatever your disease state specific goals are. All right, here are the more common things you're going to see and what are the recommendations. This is a little bit complicated to look at initially, I think, but it's not terrible. I think really what to remember is that a beta blocker plus a vasodilator are really what you're going to use. And basically you have two beta blocker options that are IV, esmol and labetalol. I'll talk about the differences and benefits of them here in a second. And then you have two vasodilators. NTP is nitroprusside, which is a much more broad spectrum one. And nicardipine is a calcium channel blocker that's going to be a peripheral vasodilator. We use nicardipine by far and away the most common one for any of these conditions, really, with maybe the exception of MI. MI, you don't tend to need a lot of blood pressure reduction, believe it or not. Every once in a while you might. What I see more commonly done is NTG stands for nitroglycerin, and that's where they use that specifically because it dilates those coronary arteries, and you get not only decreases in blood pressure, but you can increase or help with the pain component of an MI as well. So that's kind of an oddball there. Pulmonary edema or any type of CHF exacerbation, you're going to add on a loop diuretic as well. That's not going to technically do a ton to the blood pressure, but it'll work synergistically with whatever else you're trying to give. And renal emergencies, don't worry about phenoldipan. No one uses it anymore. I'm not going to test you on it. It was originally thought that it increased renal blood flow, so if you had some sort of end organ damage in the kidneys, that it might be the preferred choice, but super expensive. The outcomes aren't any better than anything else, so we never use it. A couple other more or less common ones. Catecholamine excess would be something like, I think of like a cocaine overdose, or maybe somebody with, what's a good example of this? Somebody with maybe like an adrenal tumor that's causing an over-response of adrenaline. What I would say with this is that you have to avoid unopposed alpha adrenergic blockade. The problem is if you give somebody like an alpha blocker of some kind, you can end up with all that sympathomimetic chemical, whether it's something they took or something their body's producing, going to their beta receptors and causing basically almost a heart attack or cardiac arrest situation. So the idea here is you use phentolamine, which is an alpha adrenergic blocker, plus a beta blocker at the same time. So you combine the two and you get some effect that way. Again, this isn't done very often, and most of these patients who come in with this type of thing, especially if it's like a cocaine overdose, you usually just kind of let the cocaine wear off, and you might manage them a little bit here or there with maybe some bumps of something, but at the end of the day, you don't really care a ton about their blood pressure. It's going to come down as the cocaine comes off, and it's rare to see like a full-out hypertensive emergency from that. Again, I don't know, I shouldn't say never, maybe a couple times in my career seen this, but it's not very common. Hypertensive encephalopathy, again, same kind of drugs we're going to use here. Intracranial hemorrhage, same concept, nicardipine, labetalol. Ischemic stroke, labetalol, nicardipine. Ischemic stroke has some issues with reducing blood pressure. A lot of people want that blood pressure to be right up to the TPA limit, because the idea is if you're perfusing and you have higher pressure, the TPA might get to the brain a little bit more quickly. I don't know if that's actually proven or not, but if somebody's right on that line, like if their cutoff's 185 systolic, if they're 180, they'll still give TPA and they won't give any blood pressure reduction meds because they want that pressure to ride as high as they can. That's a pretty common strategy. So usually with ischemic stroke, I don't reduce blood pressure rarely. I mean, sometimes you might give them a little bump of labetalol, like I talked about on the previous slide, but it's not as common. All right, so what's the benefit of all these drugs? This is not going to be testable material. It's just to show you the differences in onset. Most of it's pretty similar. You're looking at very fast onset. Some things like nitroprusside, they're basically immediately. As soon as you infuse them, they start to work. Nicardipine works really quickly. Nitroglycerin works very quickly. I haven't talked about hydralazine. I don't really care to talk about that right now. Oops, wrong way. Labetalol has probably a little bit longer of an onset, but it's still 5 to 10 minutes. So anything you give somebody IV is usually going to kick in pretty quickly. It depends on just situationally what you're going to use it for. I think I have one more slide on this. Oh, no. I'll just mention this now. So labetalol versus esmolol, question about which one might be better, because they're both beta blockers. They both kind of have the same effects. Labetalol is not as selective. Esmolol is a beta-1 selective specific antagonist. Labetalol has beta-1 and 2, and also some alpha blockade properties as well. But essentially, they're used interchangeably. Esmolol, you can see fast onset, quite short acting, 15 to 30 minute half-life in the body, or duration even. So esmolol has the advantage of being able to titrate it. You can titrate it to effect up and down really easily. Labetalol is almost impossible to titrate, and I hate it when people order labetalol drips because I don't know how they expect it to be able to titrate, because once you put it in, once you start getting enough accumulation, you've got it sitting around for 2 to 6 hours, and how do you bring that back down once it's already accumulated? So, we've actually seen some issues where people have tried to titrate labetalol drips up. They want to get more effect. They keep pushing the dose, and they almost end up in a beta blocker toxicity picture because they overdose the patient, trying to get them to a point where they could have just used esmolol and titrated it nice and easy. So I'm a big esmolol fan. I've used it before. I think it works really well. But again, some areas like intracranial hemorrhage, for example, the studies are all with labetalol drips, so that's what they use, even though in practical scenarios it doesn't necessarily make sense. So again, I'm not going to get in an argument with a neurologist over that, but it's something that personally I feel strongly about. So there we go. All right, moving on to myocardial infarction. All right, so STEMIs are going to be called in the field by EMS. Why anybody with chest pain, it's really important to call your ambulance first, get them in the rig, get the rig communicating with your whatever center they're going to. They can get their cath lab ready. The time the person rolls in the door, they can usually roll right up to cath lab. If you drive your person having chest pain to the ER, that's more time that they have to spend getting their cath lab ready to get that prepared so that they can give you a stent if they need to. Again, goal, get them there within 90 minutes. A good center can do it a lot faster than that. I think our metrics are below 60 right now. I can't remember exactly what they are. A normal one, a standard one that's called in the field, once they get to Abbott, they basically, they'll kind of come through the ER, maybe stop, get like a quick dose of ticagrelor, and then head right up to the cath lab. It's like 5-minute duration. Again, that's somebody if we're called out, maybe. Usually the EMS don't even take them off their gurney. They just roll them into a room and roll them up to the cath lab. Sometimes they just get admitted straight to cath lab if they're ready to. So again, good centers have this down. And again, it's like stroke. Time is very important. The faster we get them to the intervention, the better they do. Medications, nitroglycerin, sublingual or IV is going to be your vasodilator that controls some of the ischemic pain, and it's going to allow increased blood flow to some of those areas in the heart that aren't getting blood. Morphine can also be used for pain, less common. I rarely ever give morphine with these things, and I've been in hundreds of these as well, getting the meds ready, and I don't know, morphine doesn't come up that much. People just aren't in enough pain, and honestly, at our hospital, there's not enough time to get a morphine dose in the person. You're kind of shoving meds down their throat, and as they're running away from you, it always feels like kind of a rush. Aspirin load. Aspirin is available at EMS rigs, so they'll usually almost all the time have aspirin be given to them before they arrive in the ER. An aspirin load is pretty much benign if the person isn't having a heart attack, so 9 times out of 10, chest pain, especially if there's any type of EKG abnormalities, they're going to get an aspirin load. Aspirin does come rectally. If the patient's NPO or unconscious or can't swallow or protect their airway, you could give it as a suppository. Other antiplatelet load, you're going to have 3 options here. I talked about these 3 last fall. Ticagrelor has the best data for the fastest onset and most potent effects, which is why we use it exclusively. Plavix you can give. It takes a longer time. You can also give prasugrel, but prasugrel has a lot more contraindications like previous stroke, bleeding, that type of thing. Heparin load and infusion is usually done as well. Sometimes they'll use bivalirudin. The continuous infusion part I'm not super concerned about. They usually give that through the procedure. Sometimes they continue that a little bit afterwards too, but it usually ends, after a few hours of the whole, clinical picture of start to finish of the patient. And that's just to prevent excess building up of a clot in the body, just like our antiplatelet agent. There is an IV version of ticagrelor out now called Cangrelor, and it is really expensive, and it could be given to an NPO patient who can't do one of these. So that's one of the first options we have to do that, but it's not used very commonly at all. Beta blockers. Beta blockers really have not a lot of role in the acute myocardial infarction. Basically, if they're tachycardic, you can give them a beta blocker to decrease that, and that's the only time I've ever seen those used. But they're in our kits. We have all the MI meds in a little bag. It's called an MI kit. You take it out, you get them all ready, give them to the patient, then they leave. That's pretty much it. They're very uneventful. If you work in ER and you work at a place that has a good cath lab, if you work in like a small rural hospital, you're probably going to have to do some more management. In that case, you might have to get them to, if they can't get to a cath lab, they're probably going to need TPA if they can't get to a center within a certain point. But there's lots of cath labs around Minnesota. There's lots of them in rural areas, believe it or not. And the idea is to have one really kind of positioned in all types of areas for helicopter airlifts to be able to get them to a cath lab, because the outcomes are much better than alteplase. All right, talk about ACLS and then take a quick break. ACLS stuff. So ACLS kind of depends on where you do it now. American Heart has specific recommendations that they go off of, but they update them periodically. Not a lot changes every year. Little things do. Allina actually has gotten away from American Heart ACLS completely, so they do an in-house program now, and so they have some different things like stacked shocks and different dosing strategies and things like that American Heart may adopt, but usually American Heart's slow to adopt new literature, so we've kind of gone away from actual ACLS certification. But a couple things to talk about. So epinephrine is going to be the core drug for basically any pulseless arrhythmia that you're going to give to somebody. You can give it every 3 to 5 minutes, and you have no limit of doses of epinephrine you can give somebody with. I do want you to know the 1 milligram every 3 to 5 minutes for an exam. You have to know it for ACLS, so you might as well know it for mine as well. It is a beta and alpha agonist. It hits the hearts and the lungs, provides vascular support. There is some theory out there. I feel like every time I go through ACLS, they're always like, oh, I think we're going to get rid of, I bet epinephrine's going to be off the algorithms pretty soon, and it still stays around. I think in some cases there's just nothing else you can do for these patients, so you might as well try it. I don't really see epi ever going away, despite the fact that there's some evidence that maybe it does worsen outcomes in some cases. I think it's hard to tell with this specific patient population when you're looking at cardiac arrests retrospectively, but at the end of the day, you don't have a lot of choices when somebody's on a full-out arrest. If your electricity isn't working and you can't identify a source, what exactly do you do? Well, you can give them something that keeps their heart kicking a little bit while it maybe buys you a few minutes to figure out what to do next. So that's the idea behind epi. It's definitely not going to save somebody's life. But sometimes people do really respond well to it, and they keep pressures up, they keep a pulse with it, and once the epi wears off, they lose it. So again, it might buy you time to give some of your other interventions to work. Vasopressin is no longer recommended, although every once in a while a provider might want to use it. It's a 40-unit IV push. It lasts a while, and it's a potent vasoconstrictor. It doesn't really have inotropic or chronotropic effects, though. So if you're having a hard time maintaining blood pressure, it used to be in place of epinephrine for the first or second dose in algorithms, but they've removed it completely now. So I don't want you to know it specifically for the exam. You don't need to know it for or at least the dosing or anything. Just know that vasopressin is a possible option. And again, a lot of this is clinical judgment. Just because it's not on an algorithm doesn't mean it has no place in therapy. You might still theoretically use it. Sodium bicarbonate is given as 1 amp, or it comes in a big, like 50 mil equivalent, 50 mil syringe. This is not on really any ACLS medication, but I can't tell you a code I've ever been in where I haven't given an amp of bicarb at least once. The idea here is that when you have some sort of tissue damage, especially in the heart, or other places, or ischemia going on in other places of the body, you have acidosis. And so giving a bicarb bolus or even starting a drip on somebody can help with correcting that. It also helps drive potassium back into the cells, and hyperkalemia is a really common reason why people go into cardiac arrest. It's not really technically a routine use med, but it's certainly an important thing that again, I've given in pretty much every code I've ever been in. Atropine. So atropine is currently on the ACLS American Heart Guidelines just for symptomatic bradycardia, and it's 0.5 milligrams every 3 to 5 minutes with a max of 3 milligrams. They used to recommend atropine for pulseless electrical activity too, and that went off the guidelines, I think, in 2010. So the idea with atropine is if you had a symptomatic bradycardia, that if you think about like your EKG slowly getting slower and slower and slower, eventually you almost get to like an asystolic type picture. If your asystole is being caused by a symptomatic bradycardia, it actually makes a lot of sense to give atropine. So that's one of the arguments now that you actually could use atropine in an asystolic patient because they might be in a really severe heart block causing their asystole. So that's something that's actually getting revised a little bit, and that's one of the recommendations. Again, our in-house Allina one is talking about. Again, that's not on the ACLS guidelines currently, but it's just something to keep in mind. Currently, again, symptomatic bradycardia is the only approved use for it per American Heart. Calcium chloride. Calcium chloride is another one that provides cardiac membrane stabilization, and it's really commonly given in codes. Again, I swear I would probably give calcium in 90% of the codes I've been in. It's kind of like bicarb. It's just something you do. It's not going to hurt somebody who's pretty much, very close to dying, if not almost dead. And so if you're going to try something to hopefully maybe give the heart a little bit of a fighting chance, it's not a bad idea. It's also useful if they're hyperkalemic or in calcium channel blocker or beta blocker overdoses. It has some roles there. Again, not a technical routine thing, not an ACLS thing, but a very important thing that you're going to see. To go back to my little crash cart here. So if you guys don't know what a crash cart is, these are all over hospitals. Every hospital has some somewhere. They're usually like a red or a blue cart. Ours are blue at our hospital. And our top drawer looks kind of like this. It has a bunch of meds in it. So you can see we've got a bunch of epinephrine. They're really color coordinated. They're labeled. There's even, if different companies make these epinephrines, they're all going to be that same kind of brown color. So when you open up, you can see the epi really quick and grab it. And these things are, I don't know if you might get to play with these during ACLS, but basically it's a little cardboard box. You pop the end off, you screw them together, and then you've got a syringe that you can inject that's got a Lurlock tip on it. So it's really fast. They're designed to be used on demand. And we have atropine, epinephrine. Here's some lidocaine, which we'll talk about in a second. Bicarb, calcium. There's dopamine drip in here. That's a pretty common crash cart, what you'd see. All right, some antiarrhythmic agents. So these agents actually, I think of them as, like if you think about epi as maybe a band-aid to the solution, right? It's giving you some inotropic support, it's giving you some blood pressure support, but it's not really doing anything other than that. Amiodarone can actually put you out of an arrhythmia if you give enough of it. So this is maybe arguably a better thing to give early, especially if you're suspecting pulseless VTAC or VFib. Shocking is always the best, so don't get me wrong. Electricity is going to be your preferred choice. If you can get a shock on somebody immediately, that's what you want to do. But if the shocks aren't working, if you tried a round of epi, giving amiodarone like on that second round of CPR is probably the best choice to do. You can give 300 milligrams IV push. It's a pretty hefty dose of amiodarone, especially when injected IV. You can repeat 150 over that. If somebody's just an unstable VTAC, but they still have a pulse, you can do a 150 dose over 10 minutes to try and convert them out of that. But you don't bolus people. Bolusing a stable person can drop their blood pressure really quickly. If you're already in an arrest and you've got CPR going, that doesn't matter. But if somebody's awake, you don't want to do that. Lidocaine is a second option as an amiodarone alternative. It's rarely ever used. I've never given lidocaine in a code. You can give it IV IO. You can start a drip. It does have some CV and neurologic toxicity over time, but it is an arrhythmic agent. Amiodarone is more effective, and there's not really any contraindications to giving amiodarone, so I don't know why you'd ever give lidocaine over amio. Again, I've never seen that done. I've never done it myself, so it is an option. It is an ACLS, American Heart alternative. All right. Let's talk about some pressors really quick. Blood pressure support is really important for ongoing management. You can really use any number of things. Epinephrine, if the patient's responding really well to epinephrine boluses, you can start an epi drip on that person. That's usually what I do fairly quickly. If they are, if you give 1-2 boluses of epi, and it's looking like they're getting good pressor support that's keeping their pulse up, start a drip, run it at a high rate so they get that continuous infusion of the drug. Norepinephrine, dopamine, phenylephrine, dobutamine, all are situationally useful. Norepinephrine's our preferred pressor for virtually any situation. However, it's unstable when put in a drip form. So usually don't have a pre-made drip of it, so you usually have to compound it on the fly. Same thing with epinephrine, actually. So like our crash cart will have an amp of norepinephrine in it that I'll crack open, drop, put into a bag, and hang on the spot. Same thing with epinephrine. Dopamine conveniently comes in a pre-made bag. It is stable for a couple of years once they put it in there. So we do keep that on the cart, and it's really nice because you can just hang it without having to compound anything. And I know I'm comfortable compounding a drip, but is every nurse out there who might not work with codes very often compounding doing that? Maybe not. So the idea of having something in there that is a pressor, does have good inotropic support available in a pre-made drip is advantageous for that reason. Phenylephrine is kind of the same thing, that you can make it using the components in a crash cart sometimes, but it's not stable very long at room temperature. And dobutamine, really not commonly used unless like maybe a cardiac related issue where you wanted just pure inotropic support, no real hemodynamic things. So like cardiogenic shock, maybe CHF type exacerbation, they might use dobutamine. But that's going to be very specific. All right, my general tips for ACLS. For my test, I just want you to know those drugs we talked about, both the ones that are in the algorithm and are not in the algorithm. The only dose I'll test you on is the epinephrine dose. You will need to know all the doses for your ACLS test. So they'll ask you epi, atropine, lidocaine, and amiodarone. You'll have to know those four for sure, and maybe one or two other ones. But know your algorithm. So ACLS, it's all algorithm based. So when you do your super code or whatever, you have to know which algorithm you're in. Once you know what algorithm you're in, if you have the ability to retain that information, and it's all pretty easy to memorize, your rhythms, your heart rate, blood pressure, presentations, that's all stuff that you can get and use that to your advantage. Again, electricity is king. If you can give a shock to somebody, if it's a shockable rhythm, shock them as soon as possible. Shocking is even better than starting CPR. I mean, if you're going to get your AED to charge or something like that, that's great, and to do CPR during the point. But if you can get them on something quick and get a shock right away, don't delay anything for that electricity. That's going to bring somebody back who falls in public, is that AED shock. It's not going to be, or maybe some CPR too. It's not going to be the ambulance that comes and starts pumping them full of epinephrine. That's not really going to help. It's going to be that first shock or those first responders that generally get people back. Long, prolonged codes of this, generally not successful. I maybe seen one or two people come out of a really long, prolonged code. Most people die, unfortunately. All right, communicate clearly, know your role, know what to say, like that guy in the video who just kind of did like kind of mumbled something. Probably not the best way to do it. Don't feel like a dork yelling things out, it's fine. Better to communicate than not. Somebody should be in charge too, and you guys might run into this where you have maybe a physician in the room, you're in the room. There might be, like at Abbott, oftentimes I've got a PA, I've got an ED doc, maybe two ED docs, maybe two PAs. I've got sometimes a cardiologist in there, maybe an intensivist. So maybe 3 to 5 providers. So making sure somebody is in charge. When I get 3 different orders for meds, I can't do that at once. So I need priorities. So just making sure that things are communicated clearly, especially if you're running the code. That's just my advice from a person and a peon who takes orders from people like yourselves. All right. That's all I've got to say. Heroic measures, I think we know what we're talking about. I mean, sometimes you can kind of throw a Hail Mary and hope it works, but is it worth, doing something if the person's been, without a pulse or unconscious for, 30, 40 minutes? What else can you try at that point that actually has a likelihood of giving a good outcome? Real questions you need to ask yourselves when you do some of this stuff. Not saying don't, I'm just saying it's an ethical thing. Okay, algorithms, not going to go through these. They're all here. They're probably old. Just ignore my algorithms. All right, let's take a quick break. They're drilled in during ACLS, so I'll just mention them quickly. They're down here. So if you have pulseless electrical activity, asystole, or some kind of a pulseless arrhythmia, these are the causes you always want to go through, and they're going to, again, drill this into you. You're going to test on it. I don't have much to say. We'll talk about toxicology next week. Things like a lot of this would be procedural, potentially. Some of the other things, like hyperkalemia, we'll talk about here. Something like a thrombosis, like a pulmonary thrombosis, you can give alteplase acutely, so you could give it. I think I've got that coming up here in a little bit too. But just so you know those, I wanted to mention those quickly before we moved on completely. All right, anyway, let's go to pulmonary stuff. Asthma exacerbations, pretty straightforward. Oxygen, nebs, repeat your nebs, maybe continuously give a neb. Get your RT involved. They'll help you out. Steroids, usually IV steroids if it's bad enough, or maybe even an oral steroid if they respond really well to the nebulization. And then usually a burst for a couple days after that. 5-7 days is probably fine. IV magnesium is an alternate option. So if you tried steroids and you tried nebs and they still really aren't coming out of it, IV magnesium has some smooth muscle relaxation. You could try that. You just want to avoid intubation. I don't know if I've ever seen an asthma exacerbation need to be intubated. If you manage it correctly and you have a good RT with you, you should be able to take care of that without having to intubate somebody. And then again, discharge. Make sure their controller medications are optimized and available. Check their compliance with those types of things. Inhaler education if needed. And yeah, assessing their access to medications. Steroid tapers or bursts or however you want to do it. CAP, oh gosh, I like talking about CAP, don't I? I wouldn't talk about it if it wasn't so common. Seriously, I feel like half the people coming to the ER have CAP. So community-acquired pneumonia, once again, here we are back where we all started. Strep pneumo and your atypicals, that's the stuff to remember. I'm not going to spend a lot of time on this because we talked about it with kids. It's not a lot of different for the adults and the older kids, and it's no different from what we talked about last fall. Do we use azithromycin by itself? No, we don't. You don't live in a place that has greater than 25% or less than 25% resistance. No place in the United States has less than 25% documented resistance. So therefore, no place in the United States gets azithromycin monotherapy. Even if it's non-complicated or whatever you want to call it, don't do it. Okay. Doxycycline, that's an okay option as a single therapy for somebody who's relatively healthy and uncomplicated. Strep pneumo is okay. It's like 90% covered by doxy. Not great, but decent. Comorbidities, or you just want to cover all your bases, go with one of these options. Levofloxacin, moxifloxacin are going to be preferred as their one regimen. Compliance is much better. Yes, fluoroquinolones have all kinds of problems with them and possible side effects, but you're talking about a 5-day course especially if you're talking about Levaquin. Levofloxacin, 750, 5 days. Most people can finish that. It's very effective. It's as effective as a 14-day course per study. So it's a pretty nice option, why it's usually preferred. Or you can do azithromycin in combination with some sort of beta-lactam. Doesn't really matter what you pick. Studies are a little bit, here or there. A third-generation cephalosporin is pretty much going to cover any bug you can imagine very well. Amoxicillin or Augmentin, either one of those should also have really good strep pneumo coverage. So that's really what you're trying to pick up in addition to the azithromycin, and all of those are okay per current guidelines. So what might guide your decision? Allergies, age. Some people are really hesitant to give fluoroquinolones to an older person and would prefer this type of an option. Fluoroquinolones interact heavily with warfarin. That might be something you don't want to do. Azithromycin also does a little bit, but not quite as bad. So just some of those things to think about, but for the most part, go with one of these options and you're going to be just fine discharging somebody with CAP. Now, you're going to get people with CAP who you need to admit. It's very common admission to like a standard med-surg floor or even an ICU in some cases. And so that's where you basically do the exact same thing, but you can give all those things IV. So if you're just admitting them to med-surg, PO is probably fine. Starting somebody on an oral fluoroquinolone, sending them to a med-surg floor, nothing wrong with that. I think actually we don't do that enough. We go straight to IV when we don't really need to. A lot of people are like, well, they've got an IV, they're in the hospital. I want to ensure it's all getting into their body and not, some kind of some of it's not getting absorbed. Maybe they have issues with their GI absorption. Who knows? You don't know that really. So I've talked to some physicians who aren't comfortable with that. If they're sick enough to go into the hospital, they get IV. Technically, they don't need it. Fluoroquinolones are super bioavailable. They're like 100% bioavailable. And so not quite that, but it's like 99%. So you can give them PO to IV. The conversion's 1-to-1. Super easy to dose. And you can keep them PO through a hospital stay as long as they're improving. No reason to give them IV therapy. But again, personal preference, you might want to give them IV. Usually if they're sick enough to admit to an ICU, that's where you're going to give them IV therapy for sure. And we're going to up the coverage a little bit. But still, you can stick to some of the basic stuff. So azithromycin plus ceftriaxone IV is fine. That's really just an IV version of our oral outpatient regimen. Pseudomonas concern. So Pseudomonas concern would be somebody who has like previous healthcare exposure, lots of healthcare exposure, immunocompromised. Somebody comes from a nursing home, I wouldn't consider healthcare exposure. That's usually more like a community-acquired picture. Somebody comes from a ventilated care facility, definitely would be somebody I would treat for Pseudomonas. So take each individual as they are and decide their risk. Somebody who's a transplant patient, somebody who has, but even some of those people, sometimes they just treat normally too. So it really just depends on how sick the person is and how concerned you are at what they've been exposed to recently. MRSA pneumonias are not common. Adding Vanco or linezolid to cover MRSA is really only going to happen if the person's septic and you think pulmonary source and they're looking like a septic shock or severe sepsis picture, then you could add that on. But overall, wouldn't need to add MRSA coverage for most patients. Now, I will say that I'll just give a caveat here. The ED is kind of notorious for just saying, all right, well, we don't really have enough information to figure out where our source is for sepsis, so let's kind of just give them broad spectrum. And that's okay to do, especially if they're septic. And if you're looking at severe septic shock, it's better to overshoot initially and pull back than to undershoot and need to add more later. So a lot of times in the ER, we're starting people on Vanco, we're starting people on Zosyn, from what might be just a cap, but we can't really narrow that down because the person looks so sick. And then they get up to the floor, they look a little bit better, they switch to ceftriaxone, we get some cultures back, everything looks good, and then they get to narrow therapy from there. That's pretty common. So if you work ER, don't feel bad about necessarily going too broad initially. I'm not saying throw tons of broad antibiotics at everybody, but use your discretion. And if the person looks really sick and they're meeting all your sepsis criteria, don't feel bad about going with covering everything right off the bat. It's definitely acceptable, and it's indicated per guidelines. Pulmonary embolism, I was starting to talk about this with the H's and T's, kind of a common presentation as well. Massive versus submassive, mortality rates are different, size is different, the amount of blood flow it's blocking to the lungs is different. A massive PE will have about a 30% mortality rate without treatment, about 2 to 8% even with treatment. So PEs can be really dangerous if they aren't treated aggressively. But some PEs don't need it. So like a submassive PE, the person's not super symptomatic from it, you can actually treat that outpatient. So you can discharge people with whatever therapy you want. We tend to prefer the newer drugs like rivaroxaban or apixaban, but you could do Lovenox and warfarin to bridge them to warfarin. You can give them warfarin for a period of time. Depending on their clinical picture, any one of those would be fine. Alteplase would be for severe episodes. We can give TPA. There's like a 2-hour infusion dose that's given for stable patients who have a massive PE and are clinically deteriorating. If somebody's having a cardiac arrest because of their PE, you can push a dose of it in immediately. So the idea is, well, this person's got asystole, they're dying because they have a PE, there's nothing else I can do. So I'm going to shove a bunch of Alteplase in them, try and break up that clot as fast as possible, hopefully get some circulation back, maybe bring them back. But it's a really fast, and you don't have 2 hours to infuse TPA at that time. So you put it in a big syringe, going to slam it into the person. And that's an H's and T type treatment. I don't think that's on ACLS specifically, but that would be kind of getting further down the line of what do we actually do in some of those clinical scenarios. And pushing Alteplase isn't uncommon. Sometimes even if they suspect pulmonary embolism and they aren't quite sure if that's what the cause is, they'll go for it. And again, if you have a younger person, and I'm not saying we treat younger people and older people differently, but you know what I mean. If you have somebody who they had maybe a good clinical picture going into the code, or a better clinical picture, and they have maybe some clues that would lead you down to maybe they have like a hereditary clotting condition or something like that. That might give you a clue, even if you can't get imaging confirmation that they have pulmonary embolism, to give them TPA right away. So that's something we do aggressively sometimes, especially when a young person has a cardiac arrest and it's not really another picture. Their heart maybe seems fine structurally. They don't really have anything looking weird on their labs. That might be the trigger in what we clue in. Especially think of like a younger woman on birth control, slightly higher risk of VTE. That would be a clue there. Or like me, I have factor V Leiden. If I had a PE or if I pass out, that's probably what it is. I mean, I don't know what else I would have. Hopefully it's not lung cancer or something like that, but you get my point, right? You have only a certain group of things that can affect certain people. I mean, technically, yeah, they could have anything, but for the most part, a younger person, you're going to have only a few etiologies of why they're having an arrest. So it's not uncommon to give that almost empirically to try and get the person back. and that's going to be the most helpful thing in that situation. All right, gastrointestinal stuff. Really quickly, GI bleeding causes ulceration. Esophageal varices are common. Overuse of NSAIDs plus anticoagulants, antiplatelet agents, usually kind of the picture we're looking at there. Abdominal pain, coffee ground emesis, frank blood they're seeing in their stool. Supportive care and IV fluids might be all you need, depending on how much blood they've lost. Transfusion, appropriate in certain situations, of course. Overall, you want that from a medication standpoint. This is where my job would come into play, is you want to make sure that ulcer gets a chance to heal. And that's where your IV acid suppression comes into play. So we give IV Protonix or Nexium, which is pantoprazole and esomeprazole. Either one of those are IV and appropriate. We used to do these continuous infusions, and the data actually shows that giving bolus doses every 12 hours is just as effective. So now we just do that. But if you see an infusion done, some hospitals might still do a continuous infusion of a PPI, but overall it's not really recommended anymore. If you do have an esophagogastric variceal bleeding, so I think of like an alcoholic patient as being the core group of people you might see this in, IV octreotide is a product we can give that inhibits serotonin release, and so you get a bunch of limited activity of certain enzymes, and which causes a downstream effect that eventually has a potential enhancement of platelet aggregation and can help clot a little bit better. So that's commonly done. Some people will say that that's much more effective for a variceal bleed than like a Protonix infusion, or Protonix bolus. But usually you do both. So if you have esophageal bleeding, you're probably going to do both the PPI and the IV octreotide. If it's just a GI bleed, you're probably just going to do the PPI and leave the octreotide alone. Occasionally they'll do an antibiotic as well, considering there might be an intra-abdominal infection risk. So they might add something like that on, but that's not super common. All right, GI infection or prophylaxis. So if somebody has diverticulitis, appendicitis, I think those being the two most common ones, you might see urgent care ER treatment before they go to surgery if they are a surgical candidate, or if they're not. Either way, you're going to cover the same thing, gram-negatives and anaerobes. So it's usually going to be a third-gen cephalosporin plus metronidazole. You could, if somebody has allergies, you could consider a carbapenem. Ertapenem is a popular choice for that because it's a little bit less broad spectrum than our other penims. It doesn't cover Pseudomonas, and so that one is one that they like to use. It's really expensive though, so honestly, if you can get by with like ceftriaxone plus metronidazole, that's going to be ideal. That's a really cheap regimen. It's very effective as well. Prior to surgery, consult with your GI surgeon. I can't tell you, well, it's probably happened to me a dozen times, where I've talked to the ED provider about the idea for what antibiotics. I've given them a recommendation. I almost always say ceftriaxone and metronidazole unless there's a contraindication or an allergy or something. And then they call GI surgery and they say, oh, let's do Zosyn. Why are you doing Zosyn? I mean, okay, so sometimes you need a higher higher coverage for more severe things. But for an uncomplicated patient who just needs to get their appendix removed, you don't need to give Zosyn to that person for the most part. So anyway, but I've gotten burned on that multiple times where they've got their ceftriaxones infusing, and then they say, oh no, the GI surgeon wants Zosyn. It's like, all right, so now we gave them antibiotics that they don't really need. We're giving them Zosyn that they don't really need, yada, yada. Too many antibiotics. Just moral of the story in my experience is make sure you consult with GI. And you guys might be GI, and if you're GI, think about it before you say meropenem or Zosyn or something really broad spectrum if you don't really need that much broad spectrum coverage. Pseudomonas coverage, you don't need it for an uncomplicated GI surgery. You just don't. All right, some other mixed potpourri things. Psych emergencies. Acute agitation may require chemical restraint. Oh, here you go. So schizophrenia, substance abuse mania. Treatment, you can bold olanzapine IM. That's probably the preferred choice people go with right now. The B52 IM cocktail is historically what was used a lot, and the terminology has kind of fallen out of favor. People think it's, I don't know if it's offensive or what, it's like a B52 bomber, like you're bombing somebody with sedatives, and yeah, I guess it's not the most politically correct way to say it, but it is a really sedating cocktail, so I think it is somewhat accurate in its description. But B52s is Benadryl, IM, haloperidol, and lorazepam. All of those are heavily sedatives, and you've got your antipsychotic on board there, which is haloperidol. it's pretty much fallen out of favor due to the EPS associated with haloperidol, especially when you give it IM in high doses. And so olanzapine IM has been much more favorable because it doesn't have EPS. In a short dose of olanzapine, actually you don't really have any risk of too many side effects, believe it or not. Remember, olanzapine's nastiest side effects are its metabolic effects, but that's long term. It takes a while to get there. If you're giving somebody acute Zyprexa doses, doesn't really have an effect on their metabolic pathways yet. It's still really sedating. It's going to be an effective antipsychotic. It's going to calm the person down. You just don't get the weird movement stuff like you do with haloperidol. So that's why it's preferred. If you can get a person to take an ODT tablet, some person might be really agitated, but enough that you don't need to sedate them immediately, and they can take a tablet, that tablet will work pretty quickly, like 20 to 30 minutes should start kicking in. Sometimes just the act of sitting down and agreeing to take the tablet is enough to calm the patient down a little bit. Ketamine is kind of the big gun we reserve for those really agitated patients that we want to just get sedated fast. They're hurting themselves or risk hurting a staff member. We don't have time to really risk that, and we don't ever want to risk that, right? So chemically sedating them with ketamine is a very fast option. So IM ketamine is a popular choice for that. If you work in an ER well, pretty much all ERs now deal with a fair amount of mental health traffic. That's going to be something you're going to be pretty familiar with, I would say. All right, shock. Shocks, basically fluid boluses and pressors, depending on the specific source, but that's generally the pathway you're going to go. Usually you're looking at 30 mil per kilo, and if it doesn't respond to that, you're going to start a vasopressor. Usually go with norepinephrine first. You could do really any one of them technically, but that's the preferred one we use. Sepsis is a form of shock, so systemic inflammatory shock, usually infectious in source, and you have some sort of end organ damage going on. Antibiotics are key, so we're going to give them immediately after fluid boluses. So fluid boluses plus or minus pressors, give the antibiotics. The faster you give antibiotics in sepsis, the better the outcomes are. I think I've said that a number of times. And generally, you're going broad spectrum. The only time you don't go broad spectrum is if you know exactly what's causing the sepsis. So if this person comes in with a cellulitis that was growing MRSA, and it got really nasty, and they discharged on Keflex, which doesn't cover MRSA, well, there's your smoking gun. But for a lot of patients, the providers are like, well, it could be belly, it could be lungs, I don't know. And so it's like, well, okay, let's kind of cover them for everything. And that's pretty common. So again, don't feel bad about going broad spectrum initially. People who take care of the patient after, you can always narrow down based on other pools of evidence. And then there's just the surviving sepsis guidelines are available for your browsing if you'd like to, and the sepsis criteria is here. Anaphylaxis, so severe allergic reaction presenting in shock, usually aggressive immune response, likely due to some sort of food or environmental exposure. Airways issue, so if we can keep the airway open, that's ideal. Throat swelling closure, intubate if necessary. Supportive treatment, epinephrine IM. If they didn't use an EpiPen in the field, that's probably what we're going to try and use. So EpiPens have 0.3 milligrams of epinephrine in them, and they're designed to infuse quickly. I've got a picture. I'm sure you guys have all seen an EpiPen. The epinephrine we keep in the hospital is a 1 mg per mil vial or ampule, and so you have to draw out 0.3 milligrams. We've actually had issues with this where people do the wrong thing, or they draw it out and they inject it IV and cause an arrhythmia versus giving it IM. So it's really, really important that if you're telling a nurse to give this, that you are triple checking their route. It happens every once in a while. In fact, it happened, I don't know if you guys remember back in the news a few years ago, Allina had a huge nurses strike. And right during the strike, of course, one of the traveling nurses, who are actually really great nurses, they're very well trained, one of them did that. They gave 0.3 milligrams IV, and it put the person into VTAC. The person did fine. They came out of it. There wasn't any real added therapy, but it was a little bit scary, obviously. And so as a knee-jerk reaction, the hospital decided to stock EpiPens in our machines in the EDs. Guess how many nurses stuck their fingers with EpiPens? 5. So that ended up getting OC Health against them. And what happened is now we're back to the vials again, sure enough, because nurses don't stick themselves with that as much. So there's all this weird stuff about this. But the point is, for you guys as providers, if you're dealing with this, just keep an eye on what's going on, because it does happen every once in a while where somebody shoots at IV and then you're like, no, what are you doing? But yeah, it does occasionally happen. So anyway, back to anaphylaxis. Epinephrine is usually going to be the first thing you're going to give. The other cocktail is sort of like nebs for respiratory support. IV corticosteroids, usually I get like 125 milligrams of methylpred ready. 10 milligrams of dexamethasone would be another common choice. Benadryl, IV, IM would be fine. Either one route is good. And then Pepcid. So I think we talked about this last fall, but just to reiterate why we do famotidine, so our H2 blocker, is because if you have a lot of histamine response going on, Benadryl is a histamine 1 blocker, and you can shunt your histamine to H2, which can overproduce acid in the stomach. So the idea is it's basically gastric protective at that point. It can also have some carryover into the H1 blockade as well, but it's mostly gastric protective is why we give it. A couple different EpiPen options. There's been a lot of controversy about EpiPens due to some pharmaceutical companies really jacking up the price. They got really expensive, so people are like out there MacGyvering weird techniques to get an epinephrine dose that's more affordable. I think they've come back down after some political and public pressure. The AviQ product was put on the market originally, and it's kind of like, it's the same concept of an EpiPen. You pull off the thing, you put it on, and it talks to you actually though. So it has a little speaker in it and it tells you what to do. Whereas the EpiPen has these really clearly laid out instructions right on the side of it. The AviQ actually was less expensive. It went off the market though because it was malfunctioning, which of course is the last thing you want to happen in a device like this. And it is back on the market now. So they've remade it or whatever, and apparently it works. I don't know. I've never used one. I don't think I've actually seen one in person, but it is an option. And then there are generic options out there too. There are some companies making generic EpiPens. However, they are slightly different. So an EpiPen, it's generally the same concept. You're usually removing some sort of security device and then injecting the pen. But how you do it and how that device gets removed, it's all slightly different because the EpiPen device itself can't be mimicked exactly. You can mimic something kind of like it, but not exactly per patent. So that's one of the big issues behind the cost of these things. All right, hyperkalemia. We talked about this last fall. Just to reiterate our choices here. If you have no EKG changes, go straight to step 2. If your EKG has changed, so again, if you're talking about an ACLS patient or some sort of an emergent, I like to see like peak T waves starting to happen that can lead to an arrhythmia pretty quickly. Calcium chloride, stabilize the cardiac membrane. If you don't have those EKG changes, you want to go straight to insulin therapy. Insulin is going to be your primary driving factor to get potassium back into the cells. Give dextrose first if the blood sugar is normal or low, because you don't want to bottom out their blood sugar while you're trying to correct their potassium. If their blood sugar is really high, you don't really need to give dextrose. Usually I think it's like above 250 is kind of the cutoff that people generally go at. Sodium bicarb, albuterol nubs, both drive potassium back into the cells. They're kind of optional as far as I'm concerned. Generally speaking, people still do it. Is it going to be as effective as insulin? No, but it might get some of that potassium back into the cells. Lasix over time can help excrete potassium. So if you have a mild case and want to get it done, the next day, that's not a bad choice. But acutely, it's not going to be helpful. Same thing with sodium polystyrene or Kayexalate. It's an oral GI agent that exchanges potassium for sodium, and it can help excrete potassium. And that takes about 24 hours to see an effect. So again, that's kind of like your last thing that you would consider in an acute case. DKA. Metabolic acidosis with anion gap, blood sugar usually below 800, might be higher if the patient's like comatose potentially, ketone body present, fluid replacement, usually you're using potassium. So think about it when you have really high blood sugar, you're going to give insulin to correct that. That's also going to drive potassium back into cells. These patients may or may not have elevated potassium, so you want to protect them if their potassium is low especially, or kind of borderline low. You want to make sure you're replacing that as needed. And in fact, you should run a potassium level and replace that before you initiate any insulin thing. DKA is rarely like the person's going to die from it right in front of you. It's not something that people usually are really uncomfortable and sick, and they might be getting to the point where they're passing out or getting sedated or a little bit altered mental status, but it's not like the opposite of having really low blood sugar. So if you bottom out somebody's potassium, you're going to cause an arrhythmia that way. So that's worse. So let's get their potassium corrected and stabilized, and then go ahead and fix the blood sugar problem with insulin. Monitoring is frequent, but it's really doable. A lot of hospitals have protocols all set up for this. So as a provider at Allina, you just type in like an order set, and the nurse does all the labs and runs all the stuff for you. You don't really have to look at it too much. It's pretty straightforward. All right, I'm not going to do any talks today because I'm tired of talking, and you guys are probably ready to go, and we don't have much time. So talks will be recorded. Should I go over the test with you guys?
Yeah.
Yep. Okay. I forgot about that.
There you go.
How do you know?
Can't wait for the